Let's eat, y'all, y'all. Let's eat, y'all, y'all. Let's see if you can keep up with the beat, y'all, y'all. Take a seat, y'all.
Put your makeup on, get your nails done, curl your hair, run the extra mile, keep it slim so they like you. Do they like you? Get your sexy on, don't be shy, girl, take it off. This is what you want to belong, so they like you. Do you like you? You don't have to try so hard. You don't have to give it all away. You just have to get up, get up, get up, get up. You don't have to change a single thing. You don't have to try. 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 Get your shopping on at the mall, max your credit cards. You don't have to choose, buy it all, so they like you. Do they like you? Wait a second, why should you care what they think of you when you're all alone by yourself? Do you like you? Do you like you? You don't have to try so hard. You don't have to give it all away. You just have to get up, get up, get up, get up. You don't have to change a single thing. You don't.
Alrighty, so we're going to be getting to body dysmorphic disorder. So I thought that slide was a nice, that song rather was a nice intro to everything. Let me go ahead and stick on our captions, turn off the other captions. I don't know how much people care about the nitty gritty of things, but the reason I keep turning on the Zoom captions, even when I'm using the Google ones, is if I turn on the Zoom captions, it'll make me a closed caption file. And YouTube used to automatically close caption things when I uploaded it, but it won't anymore. And so this way, if anyone has hearing impairment or is in a place where you can't have the sound on while you're watching, you'll be able to watch it with the captions. So they're obviously not perfect, but they're certainly better than no captions at all. So a couple quick things. Thank you to the folks who have emailed me about the fact that for whatever reason, even though Launchpad is recording when you do things, it's not always going back over to Blackboard. So I was doing that on my lunch break today. I got through about half of y'all to fix it. So for some of you, that will dramatically change your midterm grade. So just so you know, I'm working on it. So hopefully by the end of the day today that I will be up to date with everybody and I will keep going back in and checking that. At one point, it seemed like everything was coming over. So I was like, oh, great, I don't have to go back into Launchpad anymore. But no dice. So, you know, this is just my semester to have all kinds of issues with things. All right, I'm going to try to figure out what the heck is happening with the camera here. Yeah, it should be showing me. Yeah, that's great. Is it just blurred over? Hey, there we go. Okay, it was just someone had what is that? Who is the WikiLeaks guy? Am I blanking? The guy, no, it wasn't WikiLeaks. It was like the guy who now lives in Russia who tried to like expose the fact that like the NSA is always spying on us. He would say, cover your camera. Yes. Yeah. Yeah. That makes me think of the movie with him where he was like, put tape over your camera. But I want y'all to be able to see me. So alrighty. So we have been talking about the dissociative disorders, and I want to fully acknowledge we're about a day ahead on our syllabus. This just means that at some point I'm going to give you all a work day where you can work in your groups together during class time. At this point, I'm going to keep kind of going forward and seeing where we all feel like we need the most of a break. So But just to let you know, I fully recognize that we're ahead. It's not a bad thing. I also know that some of the lectures will talk about, like, for example, eating disorders and sexual dysfunctions are each only scheduled for a day, I think. And each of those is easily a day and a half. So we might kind of like need that time. It was just a matter of me trying to work out 10 different old syllabi based on all kinds of things, and I didn't do the best job this time around, and so hopefully next time I teach the class, it will be better. So thank you all for putting up with me. But as I said, when I revised the schedule previously, your due dates will always be the same, so that yeah. Uh-huh. Oh, so, sorry, both the scholarly article you're using and the media you're using. And so what some people have done is just like listed the name of the movie, included the poster as a screenshot. And then that is not only is your reference, it's also your media representation, if that makes sense. No, not at all. So it's all one paper, and in fact, turn it all in one document if you can. It's just the reference list has to, in the past, a lot of people have only cited their article because they don't think of the media thing as a source. But it is, because you're talking about it. So yeah, just cite the movie, TV show, magazine, whatever that you're using as well. It's just I'm not saying. Exactly, just including both on your reference list. Your reference list should have 2 references at least. If you want to include more stuff, you can, you don't have to for the parameters. That's a really good question. Thanks for asking about it. And if other people have questions about that, feel free to touch base with me or ask me talks like this. Oh, another thing, like y'all are seeing Scatterbrain, Dr. Myers, which I don't normally have, but you know what, this semester is a little weird, so. So on Tuesday, exam 2 is due, so make sure over the weekend you give yourself some time to do that. I think if you go in and start it and exit and come back, it'll let you keep going, at least that's what it's done with other classes in the past. But just make sure you've given yourself plenty of time to sit down. It's written to be done in a class period, an hour 15. So it shouldn't take you too much longer than that. But that assumption is also you having studied and like memorized stuff. So it might take you a little longer just to look stuff up. So I would give yourself like 2 hours maybe to take it. So yeah, make sure that you do that. And typically people do better on the second exam and the third because you kind of know what to expect. All right, any other questions? I want to make sure I don't cut anybody off. That we get to everything important. Cool. All righty, so how the heck do we treat the dissociative disorders? Right, if someone has different personalities, if someone doesn't remember something because of dissociation, what do we do? So for dissociative amnesia with or without fugue, the leading treatments are psychodynamic therapy, hypnotherapy, and drug therapy. So psychodynamic therapists would ask patients to free dissociate and search their unconscious and hope to kind of get at the missing material that way. But in hypnotic therapy, patients would be hypnotized and guided to recall the forgotten events. Sometimes along with hypnotism or in place of hypnotism, patients will be given an injection of barbiturates, which are used to help them regain the lost memories. Often called truth serums, the key to the drug's success is their ability to calm people and free their inhibitions, which again, in theory, hypnosis should do as well, but hypnosis isn't great for everybody. So yes, there are such things as truth serums. I'm sure there are used in the intelligence community, but in this case, what it does is help people reduce that anxiety and just sort of be more open to talking about things. Now, what about DID? So we talked a little bit about this the other day. So a big thing that you want to do with DID is to help the person recognize they have DID. I mean, it sounds to people who haven't experienced this disorder like, how could you not know? Denial is a powerful thing. And especially if you have mutually amnesic alters, right? You could just think like, I'm losing time, I'm blacking out, things along those lines. So therapists try to bond with all of the alter subpersonalities members of the system. And as those bonds are forged, the therapists try to educate the patients and help them recognize the nature of the disorder. Some will use hypnosis as a way of presenting the other subpersonalities, but as I mentioned previously, you have to be very careful with that because you can unintentionally suggest personalities that are not there under hypnosis because people are more open suggestible. As I also mentioned Tuesday, one powerful tool would be to video the person so they can see themselves switching between the different subpersonalities. And then if it exists in the area, therapists will recommend people go to a DID support group because then they see other people switching and they realize like, oh, this is a thing. It's not just something I'm making up. Also, just always helpful typically to be around other folks who are experiencing similar things. You'll often try to help the client by recovering memories, particularly again, if they have these amnesic periods, if the alters aren't mutually all co-conscious. So they may use many of the approaches applied in dissociative disorders, like hypnotherapy, like the truth serums, like psychodynamic therapy. All of these tend to work very slowly in cases of DID. And therapists can try to help the clients by integrating the subpersonalities. And again, some people are cool with this. A lot of systems do not want this. They're like, no, we exist. We don't want to be sort of killed off or integrated. So in this case, the final goal of therapy would be to merge the different subpersonalities into a single integrated entity. Again, it's questionable how successful this is. Again, like Eve that we watched the video of, Chris Foster Sizemore, they did this with her, but then I think it was like 10 or 20 years later, she had other subpersonalities, other alters emerge. Sometimes they call this process fusion, the final merging. And a lot of systems distrust this final treatment goal, and many subpersonalities see the integration as a form of death, and so will not be accepting of it. And then even if you do integrate the personalities, even if fusion is achieved, that person is still going to need therapy because A, they feel like parts of themselves were just killed off. B, if they want to maintain the fusion, that often takes some maintenance. And C, oftentimes like anybody with a psychological dysfunction, folks just need some coping skills and some social skills, right? If you've been someone who's been a system for quite some time, and now you got to figure out how do I navigate things on my own, you're just going to need some skills help, right? And like I said, a lot of people now question the need for integration. All right, so next we're going to start talking about the somatoform disorders. Again, I like to include these right after the disorders of trauma and stress because these are also really stress related. So these are also called the somatic symptom disorders. Soma means body. And so folks here are overly preoccupied with their health. And as I mentioned, we're going to talk about body dysmorphic disorder because it used to be classified here, but it's actually now with the OCD and related disorders. So it's sort of like, you could argue that disorders should end up in a bunch of different places. Like in my mind, it could be classified with the eating disorders because it has similar concerns about appearance. I've kept it here just because this is how I designed my original slides, but I keep it right before the eating disorders because I think it's a nice bridge. So just fully acknowledging that. These folks either have no identifiable medical condition causing the physical complaints, or if they have a medical condition, it doesn't explain all their symptoms. So in the case of these disorders, a physical illness or ailment that is explained largely by psychosocial causes, not medical causes. The vast majority of people will see there's a couple exceptions we'll talk about, but the vast majority of people with these disorders are not purposely inducing their symptoms. They're not consciously wanting to induce symptoms. What happens is that their stress manifests in physiological ways. So when we were talking about hysteria with Freud, these are essentially the grandchildren of hysteria. That's a sort of the modern terminology for those disorders. They appear to be physical or medical, but are due to these psychosocial factors. And unlike psychophysiological disorders in which psychosocial factors interact with physical factors to produce genuine physical ailments and damage, in this case, these are psychological disorders that sort of masquerade as physical problems. So essentially what that big fancy sentence I just said is that you can have a physical disorder and have it compounded by things that are going on with you psychologically. So this is why, you know, if someone has just gotten a cancer diagnosis or things along those lines, we want to check for psychological functioning because we know things like hope actually help in the recovery process. So this is not that. This is your psychological stress manifesting as your physical symptoms. And one thing I'll just say, something made me think of it with this disorder that I really like. So as you guys know, I wrote the clinical choices activities and the publisher contacted me because they want me to revise a couple of them. And they let me know during our meeting that they're actually going to change the name of the book next time to psychopathology instead of abnormal. So they're following the more inclusive trend too, which I love. I mean, I hope it's not a trend, but like using more modern language. Okay, so these are the disorders that we are going to talk about. And as I mentioned, body dysmorphic disorder is now actually in that OCD and related categories. All right, factitious disorders. These are the exception to people not intentionally fake. These folks do intentionally fake pain or illness to be treated like a patient. And beyond just faking it, they're not just acting, they will go to extreme lengths to create the appearance of an illness. So they'll give themselves medications, poisons, other things that will affect their physical health. They can inject drugs that do things like cause bleeding. They can use things like laxatives to produce chronic diarrhea. And some may go under painful treatments and surgeries, even again, knowing they don't need to. If they just stop taking that, they'd be okay. Yeah. Exactly. Yeah. So this till DSM-5, this was what's called Munchausen syndrome. And then yeah, we'll talk about Munchausen by proxy in a couple slides too. Yeah, they changed it to factitious disorder, but most people still refer to it as Munchausen's. Yeah, good question. Yeah, so Munchausen's is now called factitious disorder imposed on self, and Munchausen's by proxy is now called factitious disorder imposed on another. Again, sometimes I think we get fancier than we need to. I think everyone kind of knew what Munchausen was. I don't know that we needed to change that, but whatever. So you have on self, you're falsifying your own symptoms and deceptive production of injury or disease, even if you're not getting disability or something like that. By presenting yourself as ill, impaired, or injured. And then factitious disorder imposed on another or deceptive falsification of those symptoms in another person, again, even in the absence of external rewards. Any presentation of another person, and I really like that your book specifies victim here because that person truly is a victim. They typically don't know or understand. It's typically someone who is in a position that the other person has power over them. So typically a child, but it could also be like an elder under care or an adult with developmental delays, things along those lines. So yes, Munchausen syndrome is the old term for imposed on self. It's extreme and it's chronic, and they induce their symptoms and they create the illness in themselves. And so Munchausen by proxy is where parents make up or produce physical illness, again, typically in children, but it can be other people in positions of less power. So they might give them medications or poison to make them ill. Children may have to undergo painful diagnostic tests, medications, and surgery. Not surprisingly, this is considered by law enforcement to be a form of child abuse. And the biggest tell for Munchausen by proxy or fictitious disorder imposed on another is when you take the child away from the parent, the symptoms go away. So that's your biggest tell. And so even before I had a child of my own, like things that people do to kids just really tick me off. And so it's just sort of like, who does this? What kind of parent does this? They're often very needy. Traditionally, it has been mothers, but it can be fathers or other caregivers. They need like attention and the praise they get from caring for their sick child. Like, oh, you're just so giving. That must be so hard. They are intelligent. They often have a medical background, so they may be a nurse or formerly worked as a medical aide or in a doctor's office in some capacity. They will deny their actions even in the face of clear evidence. They will refuse treatment, and when they are treated, or when you try to treat them, it's often unsuccessful, which again is really sad. So what typically happens in these cases is when it's figured out, the child is removed, you know, often put in custody of either another relative or the foster system, and the child gets better, which is great. The child isn't being abused anymore, and you try to sort of treat the person who was doing it, and they just kind of don't accept it. So who else does this? Not only to themselves, but to others. What we tend to see is they themselves as kids often got a lot of extreme medical treatment, extensive medical treatment for an actual physical disorder. So there's someone who may have had, you know, meningitis or cancer or something like that as a child. They often experience family problems or physical or emotional abuse in childhood themselves. They carry a grudge against the medical profession at times. As I mentioned, they tend to have worked as a nurse or a lab tech or medical aid in some medical capacity. They basically have like enough medical training to be dangerous, if that makes sense. And they have an underlying personality problem like extreme dependence. And the precise causes of fictitious disorder are really not understood, but clinical reports have pointed to factors such as depression, unsupportive parental relationships during childhood, and an extreme need for social support. And as I mentioned previously, unfortunately, clinicians have been unable to develop dependably effective treatments for this disorder. So I do have a video here.
Well, tonight we are continuing our coverage of the Angola woman accused of faking cancer to get money from a fundraiser.
So this is fictitious disorder on cell. Oh, you were actually doing something, so I didn't want to distract you. All right.
Last night in a News Channel 15 exclusive, April Landis said she has factitious disorder and that it made her think she had cancer. Today, News Channel 15's Alyssa Ivinson talked with one of Landis's relatives, and what did she have to say?
Well, she says April Landis has a history of making up illnesses, and she thinks April is lying again now. But Landis says she's never tried to scam anyone.
So you absolutely did not lie to get money from a benefit?
No, ma'am. Nope. Like I said, I'm not about money.
In an exclusive News Channel 15 interview, April Landis says she has a mental condition called factitious disorder. Landis faces 4 felony fraud charges. Police say she faked having cancer to get money from a fundraiser. But Landis says the factitious disorder made her believe she really was sick.
A factitious disorder is the development of psychological or physical symptoms. They're starving for attention. They're starving for sympathy. And there is really no better way than having a medical problem.
Dr. Stephen Ross is a clinical and forensic psychologist. He says people with factitious disorder will often go to doctors over and over with different symptoms, even create physical symptoms. But the key is it's just for attention.
A true factitious disorder, they believe that they have a real problem. Now, the point to be made is this. If there is a secondary benefit, a gain of some sort, money, getting off of responsibility for a criminal offense, that puts it into a different category, that puts it into a malingering.
Landis says she's always had migraines, fainting spells, and other issues growing up.
Stomach aches, whatever, and a lot of that actually, from what they're thinking, was, you know, all brain.
Today, News Channel 15 also talked to one of Landis's relatives. She didn't want us to use her name, but says Landis has a history of saying she's sick, even saying her kids are seriously ill. She says after a family member had a heart attack, Landis said she had heart problems the next week. Landis said she had cancer a week after her grandmother died from the disease. Now, this family member isn't buying the factitious disorder.
I don't understand it, how everything can be so real to me, but not to everybody else.
Landis showed us paperwork from the Northeastern Center in Auburn diagnosing her with the condition, and she says she still struggles.
Part of you still thinks and believes that you have brain cancer
Yes.
right now,
Yes.
at this very moment.
Landis is going to therapy once a week. She'll be in court for the felony charges on May 14th. Live in News Control.
So during that, Daryl asked a really good question. If they believe there's, are they at fault? That's a really good question. So, you know,
News Channel.
brought up on criminal charges, they could try for what's called a not guilty by reason of insanity charge with something like that. It's tricky, right? It's hard to sort of prove one way or the other. Yeah. So in theory, if it is all psychological, yes.
Well, tonight we
But that typically doesn't mean you just get off scot-free. What it typically means is that you are then put into a like state-run mental health facility to try to rehabilitate you. You know, obviously very problematic if you're using it for all these different kinds of games. You know, one thing I didn't mention, probably the best movie portrayal I've seen of Munchausen by proxy, factitious disorder on another, is in the movie The Sixth Sense. So spoilers for, again, like a 20-year-old movie. But the kid sees dead people and they try to communicate things to him, and one of the dead people he sees is this little girl who shows him where to find a videotape, and the videotape is of her mom mixing poison into her soup every day. So like her mom took Munchausen by proxy that far, and that can happen, unfortunately. And that's one of the reasons why it's considered child abuse. All right, I have a video here that is one piece of a segment on the doctors. This was like practically the whole show, so I just picked one piece. Who this a young girl woman says that her mother did this to her, basically.
Our next guest, Munchausen by proxy. This wasn't a disturbing story she watched on TV. She claims this was her life.
I spent my entire life believing that I was sick and that my body was broken, only to find out that I was never sick at all. I believe that I was a victim of Munchausen's by proxy and that my mother was the perpetrator. It wasn't until I was in a college class and we were talking about Munchausen's by proxy that it hit me that, oh my gosh, this was my life. I felt so overwhelmed and scared. I thought that I had severe asthma, that I had 2 rare blood diseases, severe back problems. I thought I had multiple broken bones and was constantly in casts and braces for those. I took a lot of medications, narcotics a lot for different reasons. I think that the sick role became my identity. When I thought that I was possibly a victim to Munchausen's by proxy, I got my records from as many hospitals as I could. I came across one record that really caught my eye that said possible Munchausen's by proxy. I was just absolutely blown away. I came across one from when I was 2 years old in which I tested positive for drug overdose with acetaminophen. My mom would report that I was vomiting. There was records that stated that I was self-inducing vomiting. I came across a record that stated that my mom was telling the doctor that I had really bad stomach pains, and then she intensely looked at me and told me to show the doctors where it hurt, and I half-heartedly pointed at my stomach. At one point, my mom really wanted me to take IV Rocephin. When she had believed that I had been given it, she claimed that it worked, but she wasn't aware that I had really been given a saline placebo. When I was growing up, I was really close with my mom. It was me and her against the world. I was in pageant when I was 4 years old. I ended up getting runners-up, and my mom got Best Mom Award. I get angry and kind of disturbed when I think back to the fact that my mom won Best Mom Award, because little did anybody know she was making her daughter sick. I feel in a lot of ways like I didn't get to have a childhood at all.
Please welcome Jordan to the show. Thank you for being here. And can I ask you the first age at which you realized maybe I was a victim of this?
Yeah, I just realized that I believe I was a victim of this last year in May. So I'm 24 now, so I was only 22 when I first realized that this was my life. There had been different signs and symptoms as I grew up where I kind of thought maybe things were a little off, but once I got my medical records and was just flooded with it all, it was all right there in front of me.
And you mentioned your medical records. I'm just going to go through a few of these so everyone watching can get a sense for what Jordan went through. First report, mother states that the emesis shoots out of her mouth and said it is like the girl on The Exorcist that vomited very hard. On examination, she has no tenderness. She doesn't appear to be dehydrated. She hasn't had any breathing problems. Her monitor hasn't gone off. Moving on. The physician wrote, I came into the room today and mother was hovering over her child. Mother greeted me cheerfully, stating, she's Miss Throw Up. A lot of fevers, reported fevers. In this case, multiple reports detailing fevers from Jordan's mother, but a normal temperature when Jordan was in the doctor's office or hospital. One states she had a history of 105.3 degrees. On exam, her temperature was 99.8 degrees. The list goes on and on. Jordan's medical records suggest she may not have had the blisters or lesions that were reported by her mother. In this case, it reads history of fevers to 107.2 during the night, per mom's report, with additional blistering rash that I am unable to see only 12 hours later.
So yeah, if anyone's interested, if you go to the doctor's website or their YouTube
Our next
page,
guest.
there are other clips from the same show, and the mother is sort of a classic Munchausen by proxy mother, where she denies everything. I didn't do any of this, even though it's obviously pretty obvious when you look at the medical records like that. And I used to have a clip, but I could not find it anywhere. It was on physical media, and we all know how well that works out on computers. But of a case where the woman was actually separated from her daughter through a court proceeding, and the daughter got better, and she still was denying, no, I didn't do anything. So it's unclear whether when they get caught, they just deny to protect themselves, or whether they truly believe they're not doing anything to harm themselves or others in the case. It's rare, which is good, right? But still, obviously very disturbing. All right, so conversion disorder, hysteria, now called functional neurological symptom disorder. This involves sensory or motor symptoms. So psychosocial conflict or need is converted into dramatic physical symptoms that affect voluntary or sensory functioning. So in this case, they are not intentionally producing them. They're not intentionally feigning them. They're not giving themselves anything. Instead, their stress is manifesting as these symptoms. The symptoms are often neurological. They can include paralysis, blindness, loss of feeling, numbness, and they usually appear suddenly at times of extreme stress and may last for weeks. These disorders are often similar to quote unquote genuine medical ailments. And so it can be really hard to diagnose them. And physicians sometimes rely on oddities in the patient's medical procedure or picture, to help distinguish the two. So for example, up here, they talk about glove anesthesia. So some people will say, oh, they have numbness or paralysis in just their hand. But if you look at the physiology of the nerves that run there, it would actually include the arm as well, if that happens. So those things are like where you have to kind of look, and it can be really difficult and tricky to get to this. They retain more normal functionings without the awareness of this ability. So the goofy Hollywood version of this is the movie Talladega Nights, where after an accident, Will Ferrell's character thinks that he's paralyzed and can't feel anything, and he takes, I forget if it's a knife or a fork, and stabs himself in the leg, and he's like, oh, stop, because he realizes he can feel it. You know, again, that's sort of a goofy version of this, but it's not that far off from what can actually happen to folks. So you have to have a presence of one or more symptoms that's affecting voluntary or sensory function. And the symptoms are found to be inconsistent or incompatible with known neurological or medical disease, and significant distress or impairment. And again, conversion disorder is still used as terminology. So here is another very brief, again, these are very brief, but gives you a little bit of an indication of what folks with this disorder look like.
Be sure to visit symptommedia.com to sign up for a free trial today.
I don't know. It just became really weak and I couldn't move it anymore.
Are you right-handed?
Yes, I am. So, of course, that seems strange. I had to finish diapering Sammy with my left arm. And ever since then, it's just been weak.
The arm you would have used to hit Sammy.
Well, yes, but I didn't. I wouldn't.
So again,
be sure to
brief, but gives you an example of like how stress could manifest in different ways here. Oh no, I don't know what happened to this one. That's too bad. Between Tuesday and today, someone took it down. But that's an example of, you know, this woman truly believing she's having some sort of neurological issue, when in fact it's not that. Somatic symptom disorder can sometimes also be known as Burkitt's syndrome, B-R-I-Q-U-E-T. And people with this disorder become excessively distressed, concerned, or anxious about bodily symptoms they're experiencing, and their lives are greatly disrupted by the symptoms. They tend to have numerous long-lasting physical ailments with little or no organic basis. To receive a diagnosis, you have to have multiple ailments. So you can't just have one of these. So for example, you need to have headache and chest pain, some sort of gastrointestinal symptom like nausea or diarrhea, a sexual symptom like erectile dysfunction or menstrual difficulties, neurological symptoms like the paralysis that we can also see in conversion disorder, or double vision. And these are often described in exaggerated or dramatic terms. Again, that very brief clip kind of showed you that, where she was like, just happened all of a sudden. And unlike conversion disorder, this tends to last for years. So this sticks around. And patients will go from doctor to doctor to doctor, trying to seek help. And again, doctors don't want to, and most good doctors, put it that way, do not want to say, oh, your symptoms are psychological, right? They want to try to figure out what's going on. And so this could take years. And if, as you can imagine, if a doctor says, I think this is psychological, they reject that and they go find a different doctor. You can also have somatic symptom disorder with predominant pain pattern. This used to be its own disorder, just called pain disorder, but they've subsumed it under somatic symptom disorder. And this is associated, the pain is associated with psychological factors, and it's marked by pain. So psychosocial factors play a central role in the onset, severity, and or continuation of the pain. And so while people with conversion disorder and sort of I want to say like typical somatic symptom disorder without the pain specifier, there we go, may experience pain. Pain is the key symptom for this specifier. The disorder often develops after an accident or illness that has caused genuine pain. And then it's like when everything is healed, when the pain shouldn't last anymore, it keeps going. All right, so we have.
It's estimated that between 5 to 7% of the adult population has this diagnosis, and that it's more common in females than males. Welcome back, Straight Talkers. Today I'm going to talk about somatic symptom disorder and how psychiatrists go about making this diagnosis clinically. But first, make sure you hit that subscribe button so that you can be the first to know when new content comes. Somatic symptom disorder is listed under the section Somatic Symptom and Related Disorders in the DSM-5. Somatic symptom disorder is a diagnosis that is made when someone has physical symptoms, but medical test results are either normal or do not explain the person's history and overall presentation. It can also include symptoms that are normally bodily sensations or discomfort that people often experience. Symptoms can be specific, such as complaints of localized pain, or they can be non-specific, such as complaints of fatigue. And in children, the most common symptoms that we see are recurrent abdominal pain, headaches, fatigue, and nausea. And oftentimes, kids will only have a single prominent symptom compared to adults who typically have multiple. So the key feature of somatic symptom disorder is that symptoms lead to excessive worry and can also affect one's behaviors. Many people will repeatedly check their body for abnormalities.
So like this is a huge difference between this and factitious disorder, for example. You saw in the clip from the doctors where she was like, my daughter's missed throw up, right? And it like didn't distress her. People who with this disorder are distressed by it.
And even avoid physical activity out of fear of damaging their body. And these patients are often seen in the primary care setting and other medical settings, but are less commonly seen in psychiatric and mental health settings. So when evaluating for somatic symptom disorder, there are 3 criteria that psychiatrists take into consideration, and these are listed from A to C in the DSM-5. Criterion A states that 1 or more somatic symptoms are distressing or result in significant disruption of daily life. Criterion B states that there's excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following. 1. Disproportionate and persistent thoughts about the seriousness of one's symptoms. Many times worry is excessive and the amount of suffering someone is experiencing is genuine and authentic. 2. Persistently high levels of anxiety about health or symptoms. What we see is that bodily symptoms and sensations are usually perceived as being really threatening and harmful, and people will often think the worst about their health, even though there's very little to no evidence to support these beliefs. 3. Excessive time and energy devoted to these symptoms or health concerns. So what we see is that these health concerns can become all-consuming and can become a central role in the identity of an individual's life. And this often affects and dominates one's interactions with other people. Patients will have high levels of medical care utilization and will seek out care from multiple doctors. They're often unresponsive to various medical interventions, and some people will complain that their medical assessments and treatments are inadequate. And despite all of this, their concerns are rarely alleviated by medical professionals. When there is reassurance by doctors, it's often short-lived, and many will think that their doctors are not taking their concerns seriously. Lastly, Criterion C states that although one somatic symptom may not be continuously present, the state of being symptomatic is persistent, typically being more than 6 months. Once these 3 criteria are confirmed.
And the reason they have a time criteria on something like this is just like, so it's not a one-off worrying about things, right? That it has to last for a while.
The next thing I'll do is see if the patient meets criteria for the various specifiers. The first thing to specify is whether or not the patient is presenting with predominant pain, and this was formerly known as pain disorder. This specifier is for individuals whose somatic symptoms predominantly involve pain. The next thing to specify is whether or not the course of illness is persistent, and this is characterized by severe symptoms, marked impairment, and a long duration of more than 6 months. Finally, the last thing to specify is the current severity, and this ranges from mild to moderate to severe. Mild is when only one of the symptoms and criteria.
And so this is, I really love that she's showing this because this is something they added to the DSM-5, that pretty much all disorders now you specify the severity, which I think is a really good addition.
D are fulfilled. Moderate is when 2 are fulfilled, and severe is when 2 or more of the symptoms are fulfilled, plus there are multiple somatic complaints, or one very severe somatic complaint. Whenever I make the diagnosis of somatic symptom disorder, I will always also screen for depression, as it is highly comorbid and can be associated with an elevated suicide risk. Now head on over to the next video.
Gotta love, they gotta make their
It's estimated that
YouTube dollars. I mean, I shouldn't judge. Good for them, for their side hustle. But yeah, so that kind of gives you an indication of the difficulty of diagnosing this and how tricky it is. So hysterical symptoms are a terminology that you'll hear used sometimes. So conversion disorder and somatic symptom disorders are sometimes referred to as the hysterical somatoform disorders. And how does that differ from medical symptoms? Well, that can be really difficult, as we're hearing, right? It can be really difficult for physicians to differentiate between hysterical disorders and true medical conditions. They often rely on oddities in the medical presentation to help distinguish the two. And then factitious symptoms, again, you have to distinguish these hysterical symptoms from people who are actually faking the medical symptoms. Patients may be malingering, eventually faking illness to achieve external gain, financial compensation, military deferments. One of the folks I've recently found on Instagram Reels, again, the TikTok for old people, that's where it is a woman who's a PI, and part of her job is often to like follow people who are suing for oh, I can't work, I can't walk anymore, and she'll just find them like walking around the store like it's no problem. So that's just malingering. But again, you can also have factitious disorder where they're intentionally producing or feigning symptoms. The malingering is, I say I have the symptoms, I act like I have the symptoms. Factitious disorder is I produce the symptoms. Right, then there's illness anxiety disorder. This is what we used to call hypochondriasis. And people here unrealistically interpret bodily symptoms as signs of serious illness. However, often their symptoms are just normal bodily changes, such as occasional coughing or sweating, things along those lines. People with this disorder can present a clinical picture that looks like one of the somatoform disorders, or the somatic symptom disorders. However, if the anxiety is great and the bodily symptoms are relatively minor, that's illness anxiety. However, if the symptoms overshadow the anxiety, they might indicate that somatic symptom disorder. But again, it can be a little bit tricky. So here are the criteria: preoccupation with having and acquiring a serious illness. One thing I would say is that unfortunately the era of WebMD has made this worse, right? Because you can go on and like diagnose yourself and put in 2 symptoms, and WebMD is like, you might have cancer, right? I knew one time that I actually just had a cold because I put in my symptoms, and WebMD was like, this is a cold. It didn't give me like, you might have throat cancer. So I was like, oh, it's actually a cold. Okay. The somatic symptoms are absent, or if they have any, they're just mild. Anxiety is easily triggered about one's health, and they'll do excessive health-related behaviors, checking their body for appearance of anxiety, looking for rashes, things along those lines. And then preoccupation with health is chronic, and it has to last at least 6 months. So if you are one of those people who occasionally goes on WebMD and freaks out, you probably don't have this. These people are doing it fairly often. All right, so again, very brief example here, but they're so good I couldn't not use them.
Cases? Be sure to visit symptommedia.com to sign up for a free trial today.
I have cancer, Dr. Gray. Dr. Singh just didn't look thoroughly enough.
Well, your blood counts are normal. In fact, all your labs are normal. Your weight is constant. All tests show you are healthy.
No, when I roll on my side in bed at night, I feel this lump in my belly slide to the other side.
Again,
Be sure to visit
ridiculously short, but kind of gives you an indication of the overinterpretation of what could possibly be going on. Okay, so now we're going to get to body dysmorphic disorder, which is what our Colby Callier song at the beginning was kind of getting us geared up for here. And again, this is now classified with the obsessive compulsive and related disorders because of the way the symptoms manifest. In terms of the defining features, once upon a time, this was known as dysmorphophobia. That was way before I even started training, so it's been a minute. And then it really, the central feature is preoccupation with an imagined or exaggerated defect in your appearance. So you might have a fixation with mirrors, you're always looking, or you might avoid them. Unfortunately, this gets so severe that suicidal ideation and even behaviors can be common. And the person is going to worry excessively about some aspect of their physical appearance and believes it's defective. But the focus is often on things like wrinkles, spots, facial hair, facial features, things along those lines. And of course, as this picture shows, unfortunately, we live in a society where there's lots of things for people with this disorder to do, right? And fairly readily available Botox, things along those lines. Fun fact, Botox stands for botulism toxin. You're putting botulism in your face. It's just a neurotoxin. So surprisingly enough, they're finding when people get it in their forehead a lot, they're starting to have prefrontal cortex issues because you're putting a neurotoxin right near your prefrontal cortex. Shocking. Sorry, I'm just like, sometimes I can't. All right, so here are the criteria. So preoccupation with having one or more defects or flaws in your physical appearance. And again, other people just can't see it at all, or I'll be like, yes, I see it, but like, it doesn't seem like that big of a deal to me. And they'll perform repetitive checking behaviors or mental acts. And again, this is why they move this over with the OCD disorders, because this feels a lot like the compulsions in OCD. So they'll check their appearance in the mirror over and over, or do mental acts like always comparing their appearance to that of other people in response to these concerns about their appearance. And this will cause significant distress or impairment. So video here about what
I didn't have children because I felt that I was so ugly that if I gave birth to anything, that child would just be, you know, like a sort of a hideous monster and something that shouldn't have happened.
It's like me telling myself that I'm ugly all the time. Like my brain just sort of working overtime, telling me all the things that are wrong. Disgusting, I am. Absolutely disgusting. I am.
If she's going through a really bad episode, it's almost like she's trying to push you away. Through the years of being with her when she's got like this, I've just learned to not react, just don't do anything. I think Leanne looks beautiful, whatever. Like, I don't see anything wrong with Leanne, but she hates me for saying that.
For the last 2 years, the love life's pretty much been non-existent, which naturally is gonna drive you apart.
It took me a long time to get into my first relationship. I didn't have my first proper relationship until I was about 20. I was just too scared. You know, there was people that I fancied. There's people I even suspected fancied me, you know? But the fear of rejection was just off the scale. The weird thing about BDD is that the fact that they're with you seems to prove that you must look okay, that you must be at least normal. You've opened yourself up to this person, and there's this fear that one day they're just going to wake up and realize how horrible you are. Like, I imagine that every single morning that they would wake up and just go, my God, what have I done?
Shouldn't be allowed outside. Normal faces, mine's like almost deformed. I hate it. I just hate it. Sometimes I just want to scratch it off.
I wanted to go back again to have a think about what was happening in your life when you first started to experience that feeling of being humiliated, rejected, put down.
Those memories had a lot of power, didn't they?
Yeah. It's hard when you see something to think that other people don't see that. It's either I'm seeing things that everybody else is seeing and everybody's lying, or there's a psychological problem and I'm focusing on different things than what everyone else is focusing on. What if they teach me all this? I understand all the thought processes, but what if I can't get past that negative image? What do I do?
So again, I really like that video because it shows how disruptive it is in people's lives, right? You heard the first woman say, I didn't have kids because I thought they'd be ugly. You saw how it was damaging people's interpersonal relationships. So people will sometimes, I think, be like, oh, this one seems like not that bad. It really can be for the people who are living in this. We know that physical appearance has changed and the expectations for it have changed dramatically throughout history. But we know that people in modern times are very much unhappy. So this was an older study, but they polled folks and said, if you could change something about your appearance, would you? 99% of men, women, 93% of men said yes. Again, this was older, so they didn't ask anyone who was non-binary or trans, which is a big flaw. So you see some of the things where they will wear uncomfortable shoes because they look good. I used to be able to like point to heels I was wearing when I taught this. The pandemic taught me I didn't need to do that anymore. So you'll see me in very comfy shoes, but I definitely used to be one of those folks. Coloring your hair, stuffing your bras or shorts, things along those lines. And obviously culturally this varies as well, right? So here you see women from a culture where elongated necks are what we expect. And so this is also very historical. So as early as 4000 BCE, Egypt had the first ever eye glitter and lipstick and rouge. And then in 3000 BCE, we saw fingernail paints, we saw moisturizers, wig making, perfumes, hairstyling, professional barbers and guilds for the first time in 303 BCE. Galen, who we talked about the beginning of the semester, he developed a cold cream. Let's get rid of those wrinkles, everybody, as early as AD 157. When people had smallpox, they would cover them with these beauty patches that kind of, I think, ended up serving the same role as tattoos. Cologne Germany developed, cologne, lotions. Avon launched in 1886. Every time I go over this, even though I've taught this class so many times, I'm always like, wow, that's been around for a while. Commercial hair dye, things along those lines. So people have been altering their appearance for millennia, right? And it only becomes problematic when it really disturbs you, as in the case of BPD. And one of the things we'll talk about when we get into the eating disorders chapter next week is sort of the men's specific version of eating disorders, which is a specifier of BDD. So how do we explain somatic symptom disorders and these bodily obsessions? So in the psychodynamic view, this represents a conversion of underlying emotional conflicts into physical symptoms. So this goes all the way back to Freud. He's the one who kind of articulated this. And because most of his patients were women, Freud looked at the psychosexual development of girls and focused on the phallic stage, so ages 3 to 5. And again, he still called it the Oedipal complex. Jung called it the Electra complex. Regardless, the idea that girls have a pattern of sexual desire for their fathers is the one thing that pretty much everyone after Freud disagreed with him about, and some of his contemporaries as well. But he argued that they recognize that they must compete with their mothers for their attention. And because the mother is in a more powerful position, the girls repress these sexual feelings. And Freud believes that if parents overreacted to such feelings, then this complex would remain unresolved and the child might re-experience sexual anxiety throughout their life. Freud concluded that some women hide their sexual feelings in adulthood by converting them into physical symptoms. Modern psychodynamic theorists have kind of strayed from that. So they continue to believe that the sufferers of these disorders do carry unconscious conflicts, but they're not related to a sexual desire for your parent. They propose two mechanisms that are at work here. Primary gain, that they're keeping internal conflicts out of our consciousness, but also secondary gain. They enable us to avoid unpleasant activities or to receive kindness or sympathy from others, which in and of itself is reinforcing, which in its own way is behavioral, right, in its perspective. So behavioral theorists also propose that physical symptoms bring rewards to the sufferers. They may remove an individual from an unpleasant situation and bring attention to the individual, which can be positive. In response to such rewards, people learn to display symptoms more and more. And this focus on rewards is similar to the psychodynamic idea of secondary gain. But behaviorists view it as the primary cause of the development of the disorder rather than a secondary one. The cognitive view proposes that hysterical disorders are a form of communication, providing a means for people to express difficult emotions. Like psychodynamic theorists, again, this chapter is one of the only times you'll hear me use that phrase for cognitive or behavioral folks. Like psychodynamic theorists, cognitive theorists hold that emotions are being converted into physical symptoms. This conversion is not to defend against anxiety, but to communicate whatever extreme feelings they're experiencing that they feel like they can't articulate without. Is there a possible role for biology in a purely psychological disorder that can produce biological symptoms? The impact of biological processes on somatoform disorders can be understood through research on placebos and the placebo effect. So we know placebos are substances with no known medicinal value, and treatment with placebos, like what they call sham treatment, has been shown to bring improvement to many, possibly through the power of suggestion or through the release of endogenous chemicals. So by taking something we think works, it might also actually trigger a response similar to a medication that actually works, because the human brain is fascinating. I think that this really goes with that video we watched where the girl's mother thought she got a lot better when she just got a saline IV, right, which was a placebo. You know, that can happen where even in something like factitious disorder imposed on another, there's a real powerful effect of you listened to me and you gave me something. How do we treat these? Again, these can be really difficult to treat, often because the person truly believes there's something physically wrong with them. So they're going to be resistant to any psychological suggestion for treatment, right? So individuals with hysterical disorders in particular are typically treated with approaches that emphasize either the cause or the symptom. So they can include drug therapy. Here we'd be using like antidepressants, as you saw from the psychiatrist we watched, said I always screen for depression because they're highly comorbid. And oftentimes the antidepressants will treat that distress that is causing them to manifest it as physical symptoms. Insight therapy can be psychodynamically oriented here, where you try to sort of go back to the past and figure out what those roots are. Exposure. So if this was triggered by a traumatic event, the exposure techniques we talked about for PTSD would be helpful here as well. Suggestion is a big one. And this is usually an offering of emotional support. It may include hypnosis, it doesn't have to. So when I was in my 4th year of grad school, I was on my placement here in a local hospital system. I actually came in an extra half day a week to get experience rounding in the hospital, because that wasn't included in my placement, but I wanted that experience. And our supervisor was great. His name was Rod Myerscough, and he had like the most soothing voice ever, like the perfect therapist voice. And we saw someone with a somatic symptom disorder at one point, and it was really interesting because we dug more into her records, and it seemed like hers might have been like more of an exaggeration than a total fabrication, because there was some history that suggested there could be something physiologically going on. But he told me about another case where the woman had conversion disorder, basically. So one entire side of her body, she felt like she couldn't move it. And what Rod did, he said, is he just sort of like built up rapport with her. And then one day he sat by her bedside and just started giving her suggestions like, you know, sometimes when people have this disorder, it'll just start going away really quickly. And like your fingers will start tingling. You find you can move them a little, and that'll kind of move up your arm. And he went through this whole almost like meditation with her about that. And the next day when he came in, she was like, "Doctor, what you said yesterday, it started to happen to me." So he wasn't saying you're making this up or your body's tricking you. He just gave her an out, basically, and she took it. And again, she might not have even consciously realized that that was happening, but it worked in that particular case. You can also just use reinforcement. So when they are engaging in behaviors like trying to move, like giving them a lot of praise and attention, because again, that's one of the common threads we saw throughout this, is that oftentimes these are folks who are looking for attention, validation, things along those lines. Some people will try confrontation, which is just an overt attempt to force patients out of the sick role. Very occasionally this will work. Typically, this is just going to rupture your relationship with the client, cause them to go to someone else, right? And start over again. And individuals who have like illness anxiety disorder, for example, are going to be given the types of treatments applied to anxiety disorders. So antidepressant meds. For BDD, we might get exposure and response prevention, where you make them like wear something that emphasizes what they have. So a few years ago, for example, we did a training to run some body image prevention, body dissatisfaction prevention groups here. And one of the things we had to do as trainers was on our last day of training, we had to wear something that we typically wouldn't wear, that would like highlight a part of our body we typically weren't comfortable with. That's really hard to do, even as someone without PPD, right? Just because like our society in general sort of teaches us all not to like our bodies, but it is really powerful. All approaches do need more study. One thing I realized I forgot to mention with body dysmorphic disorder, one of the consequences that can happen is that people will spend a lot of time, effort, and money trying to make that go away. So sort of the quintessential case we talk about as an example for BDD is Michael Jackson. So if you know anything about sort of the last years of his life, he was just getting surgery after surgery. His nose sort of caved in because there wasn't enough cartilage there anymore. And for people who have this disorder and they have the income to do that, they can kind of go down that path, unfortunately. But even, well, so one of the people I most admire in the world in terms of their professional work was one of my professors as an undergrad, and he told us that he had actually had his ears surgically pinned back because they used to stand out. And he was like, no one else in my life thought it was a problem. It just bugged me so much that I did that. And so, you know, for him, he stopped there. So I think that's one of the examples of like cosmetic surgery can be really helpful to people with just like a one-off thing. But excuse me, I know that, Jesus, pollen, okay. I know that cosmetic surgeons are actually more and more focusing on trying to recognize BDD and not feed into it, because obviously unethical plastic surgeons might do that because they're like, who cares, to get money, but the vast majority of them are trying to be ethical people And a lot of them, very similar to like primary care practices now, might have a mental health professional within their practice or someone they refer to. All right, so a summary here. Features of our dissociative disorders are those distortions in perception and memory. And then features of our somatoform disorders, our somatic symptom disorders, our physical problem without an organic cause. These are both highly related to stress. And for both, unfortunately, well-established treatments are generally lacking, partially because they're so rare and partially because they are just so treatment resistant. All right, we'll wrap up there today. Oh, real quick, sorry.
What is the difference between somatic symptom disorders, with or without pain, and doctors that refuse to acknowledge or research chronic pain?
Yeah, that's a good question. That was one thing I meant to point out, so thank you for bringing that up. Yeah, these disorders are distinct from people who are just gaslit by their doctors, right? So medical gaslighting is a thing where doctors will often, especially for people of marginalized identities, people of color, women, non-binary folks, trans folks, people from lower socioeconomic status, doctors will often sort of write off their pain or write off their symptoms. This is not that. So this is where doctors are actually like doing their due diligence and there's something there. But yeah, that's something you need to be aware of. Be an advocate for yourself whenever you're in a medical setting. And because unfortunately there are some doctors who, again, they're trying to be well-meaning, but they miss stuff and they invalidate stuff. All right, great question.